Hello and welcome to another episode of Health Matters. I am your health coach, Dr. Michael Chillemi. And in this episode, spring's coming, spring's right around the corner. What we're going to talk about is something I treated a couple of times yesterday. So I said, let me talk about it. Golfer's elbow. I know the weather's just starting to break. They're already out there on the golf course. So with that said, we're going to take a deep dive where we go beyond the surface and get into the real science behind the condition that affects your body every day. And the big thing that we're going to be focused on through a no fluff deep dive is we're going to talk about golfer's elbow. And it is a pretty complex condition that we should really get into. So don't let the name fool you, though. You do not have to swing a golf club to develop this condition. In fact, the majority of people who suffer from golfer's elbow have never ever set foot on a golf course. Mechanical workers, construction workers, rock climbers, desk workers, baseball pitchers, tennis players, chefs. These are all common conditions that does not discriminate for this condition. So if you use your forearm or hand repetitively or forcefully, you are a candidate. In this episode, we're going to be covering everything that is going to talk about the golfer's elbow, from the definition, the detailed anatomy, how many people are actually affected, how does it affect your life, how do you get it, what's the diagnosis, and some conservative care, and then possible surgical interventions. We're going to explore everything. So with that said, let's get into it. Golfer's elbow, what is it? The clinical term is medial epicondylitis. Basically, it's the inside part of your elbow. Or more accurately, medial epicondylia. Probably didn't say that right. It's a painful overuse condition affecting the medial side of the elbow. That means the inside of the elbow. It's the side closest to your body when your arms are hanging at your sides. Specifically, it involves degeneration and micro tearing of the common flexor pronator tendon at its attachment point on the medial epicondyle of the humerus. That's the bony predominance you can feel on the inside of your elbow. You feel it right in the inside here. The muscles and tendons that flex your wrist and fingers and rotate your forearm all converge at one single point. And when they are repetitively stressed beyond their capacity to recover, tissue breaks down. Here's the critical nuance. Despite the name epicondylitis, which implies inflammation, research over the past decades has shown that the primary pathology in chronic cases is not inflammation, but degeneration. Histological studies, basically underneath the microscope, when they looked at tissue from chronic golfer's elbow, consistently showed angiofibroblastic tendinosis, a process characterized by disorganized collagen fibers, increased fibroblast activity, and vascular ingrowth. Without the classic inflammatory cells you would typically expect, which when you have anything that says itis at the end, is usually an inflammatory condition. This distinction matters enormously for treatment. So if it's an inflammation, you're going to treat it a certain way. If it's something different where it's more collagen, you're going to treat it another way. So golfer's elbow is not truly an inflammatory condition in most cases. Most time, it's a degenerative tendinopathy. This is why inflammatory treatments alone often fail. So here's the next question. How many people get golfer's elbow? So golfer's elbow is less common than its counterpart, lateral epicondylitis or tennis elbow, but it's by no means rare. It's typically affecting 1 to 3% of the general adult population annually. Among certain occupational groups, the rates climb significantly. The condition peaks around between 40 and 60, though it can occur at any age. Unlike tennis elbow, which is significantly favors women for golfer's elbow, has a more equal gender distribution, affecting men and women comparatively, though men in heavy manual labor occupations tend to present with more severe cases. From an occupational standpoint, medial epicondylitis is classified as a work-related musculoskeletal disorder. It accounts for a significant portion of elbow-related workers' compensation claims in industries that involve repetitive forearm and wrist use. Recovery can be prolonged. In many cases, it can take anywhere from 6 to 24 months. That's a long time to fully recover. And a subset of patients develop chronic treatment-resistant symptoms that significantly impair their working capacity. Up to 20% of golfers' elbow cases become chronic and resistant to standard treatment, underscoring why early and accurate and comprehensive management is so important. So now you got a little bit of information about it. Let's get into the anatomy of it. So to do a thorough anatomical walkthrough, because understanding the structure is always essential to understand why this condition develops, why it hurts, and why it hurts where it hurts, and why treatment may or may not work. So the medial epicondyle, so the humerus, your upper arm, this is your humerus, your upper arm bone flares out at its lower end with two bony points at the end called epicondyles. The lateral epicondyle is on the outside and the medial epicondyle is on the inside. Anytime you hear the word medial, it always means on the inside, and lateral always means the outside. And in its center is, and it is the central character in today's story. So the epicondyle is the origin point or the bone anchor for the entire group of muscles that flex the wrist and flex the fingers and pronate the arm, right? Pronate means you're going to bring your hand out. Ha, I lied. That's supinate. We're going to pronate. It's going to bring your hand down. So pronate's going to bring your hand down, and then it's going to flex your wrist and fingers. It serves as an attachment for the key stabilization ligaments of the elbow. The common flexor pronator tendon is not a single structure. It is a shared origin of 5 muscles, all converging at the medial epicondyle. Think of it as a thick rope where multiple cords braid together to one attachment point. Those 5 muscles are the flexor carpi radialis. So the flexor carpi radialis flexes and radial deviates the wrist. This is typically the most affected muscle in golfer's elbow. The flexicarpal ulnaris, it flexes and ulnar deviates the wrist, frequently involved in throwing athletes. So if you're a baseball pitcher, it's very common. Palmaris longus, a small, often absent muscle that weakly flexes the wrist and tenses the palmar fascia. Flexor digitorum superficialis. Say that fast 10 times. It flexes the middle joints of the finger involved in hand grip with intense tasks. Pronator teres rotates the forearm, palm down, critically involved in golfer's elbow among overhead athletes and manual workers. The most vulnerable zone is the area where degeneration most commonly begins is the proximal attachment of the flexor carpi radialis and the interface between the flexor carpi radialis and the pronator teres, just at a slight distal to the medial epicondyle. This zone receives the highest mechanical stresses during wrist flexion and forearm pronation activity. So basically, it's going to be approximately right in here. So key structures that we want to talk about. The medial epicondyle it's a crowded neighborhood, and several critical structures live in this area that are very close to its proximity to the tendons, which is why golfer's elbow can produce symptoms that go well beyond simply the elbow. First, the ulnar nerve. The ulnar nerve passes directly posterior behind to the medial epicondyle through a groove called the cubital tunnel. It is the nerve that is responsible for the AKA funny bone sensation. And if anybody's ever hit their elbow, which we all have, there is nothing funny about the funny bone. It hurts, you see stars, it tingles. So it's the bony point towards the end of your elbow. So in golfer's elbow, the combination of tendon thickening, local inflammation, and altered elbow mechanics can irritate or compress the ulnar nerve, producing numbness and tingling in the ring and pinky finger, and weakness in the intrinsic hand muscles. Studies have shown that the ulnar nerve involvement is involved in about 60% of golfer's elbow. Second, the medial collateral ligament, or the UCL, ulnar collateral ligament. This strong ligamentous complex runs from the medial epicondyle to the ulnar and is primarily the stabilizer of the medial elbow against valgus or outward stresses. The common flexor pronator muscles actually provides dynamic reinforcement to the ulnar collateral ligament. When they are weakened or painful, the ulnar collateral ligament bears more stress. And in throwing athletes, the combination can lead to ulnar collateral ligament injury or rupture. Third, the medial antebrachial cutaneous nerve, a sensory nerve that supplies the skin sensation over the inner forearm. It can be stretched or compressed in the medial elbow pathology, contributing to a burning hypersensitive skin over the inner forearm. So how does tendons break down? Tendons are comprised primarily of type 1 collagen, organized in a highly structural parallel fiber arrangement. This architect gives tendons their enormous tensile strength. The cells within tendons called tendinocytes are responsible for maintaining this structure. I like that word, tendinocytes. That's a really cool word. Sorry, a little geeky, but tendinocytes, that's a cool word. When when the flexor pronator tendon is subjected to repetitive loading that exceeds its normal capacity, it tends to weaken. And when you weaken it, the ability to cause tears is common. You typically have micro tears that start accumulating faster than the tendinocytes can repair them. So the normal parallel collagen architecture becomes disorganized. So instead of being parallel, they become crisscrossed in all kinds of different directions. That loose alignment can become wavy and haphazard, and the new blood vessels grow in the normal avascular tendon tissue, a process called neovascularization. Alongside them comes the new nerve fibers. These nerve fibers are pain fibers, which is why tendinopathy produces such persistent, deep, aching pain. The tissues become thicker, weaker, and hypersensitive. The painful tendons in golfer's elbow is not inflamed. It's degenerative, disorganized, and invaded by pain transmitting nerve fibers. That's why it hurts. And that's why healing requires a fundamentally different approach than treating an infection or an acute injury. Living with golfer's elbow, what could you expect? So the symptoms of golfer's elbow seem simple on paper. Pain at the inner elbow, but the reality of living with this condition can be surprisingly disabling. Let me walk you through the picture of it. So pain is the primary symptom, a dull aching pain, sometimes sharp at times at the medial epicondyle that radiates down into the inner forearm towards the wrist. It is provoked by any activity that loads the flexor pronator muscles, gripping, squeezing, throwing, swinging, typing, turning a doorknob, carrying a bag, shaking someone's hair, and in severe cases, even the weight of the arm itself can produce pain. Morning stiffness is common. The first movements of the day produce an aching, creaking sensation in the elbow that gradually loosens with with use and worsens as the day moves on and with activity. Many patients describe a predictable warm-up period before they can function at a reasonable level. Grip weakness, it is frequent and functionally significant. The flexor pronator muscles are critical for grip strength. And when they are painful, grip becomes inhibited both by pain and by true neuromotor inhibition. The nervous system consistently and consciously limits muscle activity to protect the damaged tissue. Activities that require sustained grip using tools, lifting weights, carrying groceries, playing an instrument can become extremely painful. So, little side note, I have definitely had this in my time and I periodically have it now, especially when I'm lifting weights. I definitely notice when I'm doing any type of overhead biceps, triceps, or and even chest. I'll actually wear a little bit of a support to give myself a little bit more strength in there so I don't irritate. Because I have irritated it. I've treated it. I've done really, really well with it, but I'm smart with it. And that's one of the things that you should know about it, right? So if you know you have a a predisposition or you previously injured it, you're going to want to protect it. You're going to want to be smart about what you're doing, how you're doing it, and you just want to make sure you take some precautions. So be smart. That's how you should do it. Be smart with everything you do. Okay. So let me get back. When the ulnar nerve is involvement is present, which we discussed is present in up to 60% of the cases, patients experience numbness and tingling in the ring and small finger, and weakness in the hand's intrinsic muscle. Fine motor tasks, grip and pinch strength is further diminished. Sleep disturbances. So when you're lying on the affected arm, you compress the elbow and aggravate the symptoms. Night pain is less common than shoulder conditions, but does occur in moderate to severe cases. Occupationally, golfer's elbow can be career threatening for people who have manual labor jobs, throwing like an athlete, um, a skilled musician, a chef who's constantly lifting heavy trays and pots and pans, surgeons. The condition can make their core professional tasks almost impossible to perform. And the psychological toll of chronic pain, restricted function, and uncertain recovery is really giving patients anxiety, frustration, depression, and common companions to the painful aspects of this condition. So, how do you typically get golfer's elbow? At its core, golfer's elbow is a load management problem. It occurs when cumulative mechanical demand placed on the flexor pronator tendon exceeds tissue capacity to adapt and repair. But the specific cause and risk factors that create this imbalance are varied and worth exploring. So, repetitive occupational and recreational loading. Any tasks requiring repetitive wrist flexion, pronation, or sustained gripping can overload the medial epicondyle. The occupational groups most at risks include construction, carpentry, anybody who uses hammers, wrists, plumbers, pipe fitters, meat cutters, computer work, especially for poor mechanics. In sports, obviously, golf is going to be one of the big athletes out there. Obviously, it's called golfer's elbow. Pitching, rock climbing, racquetball, all of those things are going to be very difficult to treat. So, how do you diagnose golfer's elbow? Diagnosing golfer's elbow means you need to get a really good history, a really good physical examination, and you should have x-rays, electrodiagnostics, and a full understanding of how you got it, where the pain is, when it starts. You really got to do a great history and a very good physical examination because you want to identify and distinguish between golfer's elbow, tennis elbow, basic muscle sprain strain, right? So there's a lot of distinctions you have to do, and usually you're going to weed that out on your physical examination with some of your muscle tests, some of your orthopedic tests, and whatnot. Um, and and then typically MRIs can provide high soft tissue resolution that are variable when trying to diagnose uncertain conditions or if you're not sure, right? You're going to want to see the tendons and the ligaments and whatnot. So, how do you treat this condition? The vast majority of Garfield's elbow cases, somewhere between 80 to 90%, can be managed very successfully without surgery, provided the treatment is comprehensive, evidence-based, and consistent. So let's go through some of the approaches. The foundation of all tendinopathy treatment is load management. So that doesn't mean you completely rest. In fact, complete rest is counterproductive as tendons require mechanical stimulus to remodel and heal. The goal is to identify and temporarily reduce the specific loads that provoke pain beyond the tolerable threshold while maintaining gradual increases over time. A counterforce brace, or basically it's a strap that's worn around the forearm just below the elbow. You want to unload. You're basically looking to offload the joint and reduce pain. Typically, the first line of defense with this is going to be physical therapy. It's going to be the cornerstone for golfer's elbow rehab. Um, and it goes way beyond just stretching and ice packs, right? So it's eccentric and isometric exercises, the engine of tendon healing. The most important therapeutic intervention for tendinopathy is backed by extensive research and progressive tendon loading exercises. The two most evidence-based forms are eccentric exercises and isometric exercises. Eccentric exercises involves loading the muscle and tendon while under lengthening it, and isometric is sustained muscle contractions without joint movement. All are going to be done by the physical therapist in a controlled environment. It's not I have patients that say, "Hey, doc, can't I just do this at home? Can I go to the gym?" It is not the same. It is completely different. What the therapy that you get in an office to understand your weaknesses and try to train and heal your muscles is incredibly different than going to the gym. Please don't ever confuse that because it is completely different. And then physical therapists are going to do manual therapy to do some cross friction, deep transverse massages, and some mobilization to help mobilize the area. They're probably also going to do some therapeutic modalities, whether it's um, electric stimulation, extracorporeal shockwave therapy. Shockwave therapy has been a tremendous breakthrough for this condition. It delivers a high energy acoustic pulses to the tendons, stimulating a biological healing process, disrupting calcification and desensitizing pain fibers. It's been really a breakthrough for a lot of patients. Multiple randomized controlled trials support its evidence for chronic tendinopathy. Okay, what else could you do? Chiropractic. That's what I do. So chiropractic management of golfer's elbow is a sophisticated multi-level approach that addresses structural contributions from the cervical spine to the wrist and much in between. So just as with carpal tunnel syndrome, golfer's elbow frequently exists in the context of proximal neurological compromise. The nerve roots contributing to the medial elbow are primarily C6, C7, and C8. Cervical disc pathology, foraminal stenosis, or vertebral dysfunction at these levels can sensitize the entire median and ulnar nerve pathways, making the elbow far more vulnerable to the effects of local tendon overload. This is another example of a double crush physiology. Double crush is when proximal nerve is compromised, amplifying distal symptoms. So typically in chiropractic, we're going to adjust the cervical spine and then also work on your tendons and ligaments that go down the arm and through the elbow, as well as doing a elbow or well, we're going to do an elbow manipulation